For those of you who don't know me, I'm Michelle Berry, the director of the Center for Innovation in Global Health. I want to thank everyone for joining us. I think this will be a very interesting global conversation. As you know, these global conversations, we try to bring iconic people to actually come and talk. And we're thrilled to have Jim O'Connell, who's really dedicated his career as a doctor and nearly 40 years of his life to providing dignified, high-quality care to people living on the streets in Boston. He's received many recognitions of his work, including the Albert Schweitzer Humanitarian Award, the Trustees Medal at the Massachusetts General Hospital Bicentennial, but probably his biggest award is having Tracy Kidder write this amazing book about him called Rough Sleepers. I was amazed last night. I heard Tracy Kidder actually shadowed him for 5 years. Like, it's amazing. He graduated from the University of Notre Dame in 1970, received his master's degree in theology from Cambridge University in 72, and then graduated from Harvard Medical School in 1982 and completed a residency in internal medicine at Mass General. I hope you realize there was a big gap of 10 years. He actually started medical school at age 30. Over the years, he then agreed to what was supposed to be a one-year stint helping the homeless and caring for the homeless at the Boston Health Care Program. But he quickly learned the critical importance of providing continuity to care for the homeless, and particularly for patients whose lives were really characterized by chaos and unpredictability. And so he really began a lifelong commitment. He's president of the program he founded, which now serves over 10,000 homeless clients, well, individuals and families, we wouldn't call them clients, in 2 hospital-based clinics and 30 shelters and outreach sites and on the streets. Over the years, faced with public health crises from TB outbreaks to HIV epidemics to the opioid crisis, Dr. O'Connell and his team have implemented many innovations to teach and reach and serve people living on the streets. They've assembled teams of providers. It's not about doctors going to the person. It's really about, we learned this morning about the extraordinary teams he's put together. He's also founded the first medical respite program for homeless or unhoused people. And how do you feel about this unhoused issue? I'll finish the introduction. I'm just curious.
I'd love to interrupt that introduction.
No, you can't. Okay. You can. I'll get back to that. This pioneering program really is all about palliative and end-of-life care. Dr. O'Connell served for many years as the National Program Director of the Homeless Families Program of the Robert Wood Johnson Program, the U.S. Department of Housing and Urban Development. He works at Harvard Medical School, and his work here, even though it's based in the U.S., I like to call it global, because it really approaches many of the global issues that we do in global health as well as locally. He's a very good friend, or was a very good friend of Paul Farmer, and I think he exhibits many of the attributes that Paul has. So I want to thank you for joining, and I want to also welcome Paul Costello, who's an amazing communicator and interviewer, has been for years, and he'll lead the conversation. Paul for 17 years was the chief communications officer at Stanford Medicine and a senior communications strategist. And today he serves as a global health faculty fellow and also an adjunct lecturer in the Department of Medicine. So Paul, over to you.
Thank you, Michelle. And Jim, good to talk to you. You know, when we spoke a couple of weeks ago, you said you had been to Stanford one time before, so welcome back. You said you really liked it, loved it, etc.
Although I have to interrupt you to say, I came one day in December and it was pouring rain. And I came today and it's completely cloudy. So do you guys ever see sun or what?
California is sunny.
This is just a jealous Bostonian.
Yeah, maybe you brought the Boston weather with you. on Monday, the U.S. Supreme Court heard arguments about a very controversial ordinance in a small town in Oregon. And the government in Oregon, the city government, was trying to enforce a rule that they could go in and capture and move homeless people out. The Supreme Court heard the arguments on Monday, and it was interesting to hear the feedback. I mean, a lot of what I read and what I heard was a feeling that the court, the conservative court, was feeling that, first of all, we shouldn't be in charge of this. It should be going back to cities. They should be the ones in control of it. What are your thoughts about this sort of the capturing of the whole debate that's going on in this country today that really seems to be emphasized by what happened in the Supreme Court?
Yeah, no, we've actually been, we step back, I think this is probably the most important case ever on homelessness before the Supreme Court. And we've been struggling a lot with it. I think the issue, I'm sure everybody knows, the issue is, can you move people? Can you accuse people essentially of being criminal for sleeping outside in public places? That's what it boils down to. And you probably know there was an earlier decision by the Ninth Circuit about Boise, which said you can't really move people unless you have a place for them to be. And this one is a little bit different, and I don't quite understand the nuance, but it's more about the criminality of it rather than the. But essentially, it's going to be if you're in a public space, can we move you? And if you don't move, can we, assess fines and eventually arrest you? So it's put broadly into, are we criminalizing homelessness? And I think every time we go down that path, where I completely understand how complicated the issue is, and it's really difficult for mayors and citizens, but to sort of, when we don't have enough housing in this country and when there are people who have no place to go, to accuse them of being criminal when they're sleeping in a public spot just feels like not in the spirit of who we are as a people. So I worry a lot about that because, I can see what's going to happen if cities are allowed to do that. They're going to sweep people away, and then I think there's a lot of evidence to show that doesn't help very much. If anything,
I'm sorry to interrupt. Is it possible to move your microphone up a little higher?
Oh.
I think maybe in the back. It's hard to hear.
Can you not Can you hear me better if I do that? Or no? Is
much
that better?
better.
That's better.
Is
Okay.
that better? Yeah.
I'll
Thank
put
you.
it up a little closer here, maybe. Is that okay? No. Can you hear me
Yes.
okay? I can't hear anything. It feels
Okay. We're seeing none. Yeah.
maybe up here.
Yeah.
So sorry. So can you hear me if I do that? So I was basically saying I don't feel comfortable making homeless people criminals because they don't have a place to live. And I think the other thing I was saying, it does make sense to me if there is an alternative you can offer to people, then it becomes a different story.
The empathy for homeless has changed dramatically in this country. And you've been involved for 40 years, and you thought you were going to be involved for 1 year. We'll talk about that in a bit. How have you seen it change, and how have you seen attitudes change? And we now have this Supreme Court decision coming down, which sounds like it's not going to be favorable to homeless. How do you feel? What's happened in this country?
I think several things, and I worry about this a lot because I certainly see the public opinions going, this is a tough problem, and you're starting to blame the people who are there. I remember in Labor Day of 1991, the New York Times had an above the fold thing on compassion fatigue among people dealing with homelessness. This is now 35 years ago. And it was interestingly written by Isabel Wilkerson, who at the time was the beat reporter for the Times. And it described a little bit of what I feel is happening now, is that it has become so complicated. If you look at, just think about the difference between East and West Coast cities, let you know we've got many, many different problems going on all under the rubric of homelessness. And I was saying this morning, for those of you who aren't from Boston, in Boston, like New York and several other Northeast cities, tonight, 95% of everybody who's homeless will be in a shelter. And you can argue about a shelter's good or not, but they're in a shelter. And only 5% or less will be out on the streets. Whereas when you come to this side of the country, it seems to be reversed. And so you can see there's different issues going on, and who is outside here looks very different than who is outside in New York or Boston. And we tend to equate them, which is a mistake. They're very different. So I think what's happened is because the problem has seemed so intractable, despite so many efforts, and really good efforts at times that have shown the way to solve this but never have been scaled, then people are getting discouraged. And it's become, a mayor, the mayors are realizing they can only do so much without the help of the federal government. The federal government hasn't really moved in to bolster housing. And as long as we have this income divide, which is growing in most of our urban cities, and housing being so unaffordable, I don't see that people just get discouraged. How are we going to solve this? I just hope we don't blame the people who are stuck in that. Instead, we sort of look at ourselves and say, what did we do wrong?
During the last 5 years, California devoted $24 billion to homeless programs. And a recent report came out that they weren't really, the outcomes, the state monitor really didn't do an adequate work on how the dollars were used, the outcomes of those dollars. And it's things like this that probably feed into the negativity that people feel. $24 billion in 5 years.
Yep.
And we have an ever-growing problem. We have a monumental problem here. So what do you tell people when they confront issues like this, when they come to you and say, Jim, help me understand how I can be compassionate, how I can be, empathetic, how I can be caring when the push is so dramatic on the other side?
I usually try to run away from that because it is, if you look at how do you solve this problem, and particularly in the particular milieu we're living in right now, I don't see it being fixed because $24 billion, when you think about it, that's what California put in it. Do you know how much it would cost? I was just looking at this the other day. So public housing in New York, which was a really pretty amazing effort, to get the public housing that currently exists in New York City up to code is going to cost $72 billion. And that's just the current housing up to code. And so when I say 24 billion, I think that's really nice, but it's not going to make a dent in the big problem. It might show people the way to do it. And then I want to run because then I was mentioning this morning, we struggle because there's, how do you solve this problem? How do you end homelessness? And the answer to that is, I think, maybe trillions of dollars of housing across the country, not billions. And it's going to require a really fundamental change in how we do our schools and, how we make reparations to people who have been blighted by so many institutional issues. And that's going to take us all as a society to do that. And then I crawl into this little niche that we're in, but we've got all these people who are currently homeless. They don't have any place to go. And they're suffering from all of the drivers of health that, or ill health that have caused. And our job, at least we crawl into our job is to try to take care of them as best we can. But we're not ending the problem when we do that. We can take really good care of people, make sure they, have the best of care that we can do, best mental health care, best substance use disorder care, and then best medical care. But that doesn't end the bigger problem. That's going to be society as a whole. So I think we have I just submit to you, I think we have a problem in our country where we look to the people who are the emergency responders to fix a problem that is really going to be fixed by the people making the policy decisions.
You've been involved in this for 4 years, as we talked about. Take us back to the point, you're finishing your residency. The hospital staff come to you and say, Jim, we want you to go out and we want you to be part of this homeless program that's just beginning in Boston. What did you think? How did you, when you entered this, that was not a career path you thought of. What did you think and how did you grab that?
I was trying to look around to see if Julie was here.
I'm
Is Julie here? Do you
Yeah,
know?
here.
Oh, you're here. You are here. Okay. So Julie knows this all too well. So Julie and I were residents together. And I have to say the local Harash, who was a medical student, Julie, with us in 1990, late 90s, spent 2 years on Pine Street and on the van with me. So I'm among friends here and you can know. So a couple things. One is, I didn't want to do this. I got told to do it. So I want to be really clear.
Why didn't you want to do it?
Well, because I loved oncology. I was going to become an oncology fellow, and I was finishing my residency, and that's where I was going. And parenthetically is we have to talk about this at some. But I was also 37 years old and hadn't had a job yet, so I really wanted to get on with my career. And this looked like a diversion. And because our chief of medicine, who was John Potts at the time, was really persuasive. So I said yes, mostly because I wanted to hang around Mass General someday. I didn't want to violate my chief. So I did it for a year, but not happily or not really willingly. But I thought I owed it to, to myself to give back at that place. But for a year, I thought that would be okay.
You walked into a room full of nurses, and they weren't welcoming. They were sort of, I'd say, hostile to you. What was that? How did you react to that? You thought, I believe you thought that they were going to welcome you, and here comes a doctor, we're so happy, and they weren't.
No, I don't know if there's any nurses here, but you remember that. But I have an older sister who's a nurse, the only person in my family who's a nurse. And so I know the one side of nurses that can be pretty vicious. And we also knew it in the hospital that your life as an intern and resident was completely dependent on how well you treated the nurses. So I have huge respect for the nurses. But when I walked into the shelter clinic, this is an 800-bed shelter in Boston, okay? And the nurses had been doing a clinic there. They were mostly volunteer nurses from the Boston City Hospital emergency room. And they had been taking care of homeless people there for 15 years, but as they would point it, without the help of doctors. Thank you very much. So when I walked in thinking they were going to be thrilled to have a doctor finally, and it was I thought everybody was going to be welcoming me, but they just had not had good experience with doctors. And so they sat me down and read me the riot act about how we had been trained all wrong. We go too fast. And that I was going to have to pay attention, sit down and pay attention, and they'll teach me how to do that. So it was my first real lesson in true humility.
And Barbara McGinnis was a key person in your life. She was a nurse, and she was a key person in the facility. What did you learn from her? What did she teach you, and how did she deal with you as a physician and as a person?
Barbara, well, first of all, I came to adore Barbara, but Barbara was, hard scrabble. You guys would remember that, and was real Bostonian, had a real thick Boston accent and a high-pitched voice. But she knew every homeless person in Boston. She had been doing this forever, and I was stunned by how well. So I wanted to learn from her. So even though she looked at me and she said, "Why are you doing this?" I'll never forget it when I got there and I said, "I'm doing it because I got told I got to do it." And she went, "Good," because then she went, "We don't want any saints or zealots here. They're awful to work with." So she just wanted to have somebody who's doing it as a job, right? And she was great from that point of view. She just taught me how to slow down. You probably know the story. I had to soak feet for 2 months. That was all I was allowed to do. And
talk about that a minute. You had to soak feet.
Yeah, the nurses, those of you who don't know this, so the nurses did this brilliant thing where, these are hardcore long-term homeless people living in this crazy shelter that was complete chaos, but they would invite them into the clinic, and around the periphery of the waiting room, they would let people sit in the chairs and soak their feet. They would invite people in to soak their feet. And I thought, I'd walked into some sort of biblical Holy Thursday night or something. And couldn't figure out what they're doing, but it was magic because everybody who had been standing in line all day, walking around, was able to sit down, and the nurses would take care of them, and they'd soak their feet. It was incredibly soothing. And I learned, because Barbara made me do that too, they took away my stethoscope and everything for the first 2 months. And Barbara, taught me that you're at the foot of the person you're serving, so it's really away from the personal space. And I hadn't quite realized we're never more than like a stethoscope away from somebody's most personal space. And the other thing they did was always call somebody by their name. It was always, "Mr. Williams, can I offer you a thing?" And I watched people light up when somebody said their name with some sort of kindness in general. So I started to pick up that there's some brilliance behind all this. And then the other thing is it's incredibly soothing. Most people who have been walking around have lots of issues going on with their feet. And I started to learn a lot about foot care, which I had not paid attention to at all. And then it just made us, well, we weren't allowed to ask anything about what what's bothering you, all we could do is say, how can I help? And that was like, it was almost impossible to do after training, where you went into a room and you had to get a chief complaint and examine someone to come up with a diagnosis. This was just stepping way back. And what I remember is I felt incredibly, I remember thinking, this is not what I chose to do, and that I should really be at my oncology fellowship right now. And it was pretty smelly. That's what I remember. The smells were overwhelming. But as I got to know the people and did that with the nurses, it became almost magical. It was really quite extraordinary.
How did they relate to you? You're down washing their feet. How did the men and women whose feet you're washing relate to you as a physician, relate to you as a human being?
Well, most of them didn't know I was a physician. So that was part of the brilliance of the nurses. They didn't want anybody thinking.
To know stature.
Right. But there was one guy who I had seen in the emergency room. I don't know if I've mentioned this story before. There's one man who I had seen in the emergency room a lot, and I had to soak his feet. He had a really long-standing schizophrenia that was very paranoid about stuff. And so I was soaking his feet, and he kept looking at me like crazy, and I was trying to hope he didn't recognize it. And one night, probably a month after I'd been soaking his feet, he looks down and he goes, "Aren't you a doctor?" And and I remember he was the first person in the shelter that said, "Call me doctor." And I realized I was just like the homeless people having their names called. I felt, yes, I am. And then he just looked at me with kind of a scowl and he goes, "What the hell are you doing soaking feet?" And I had no answer to give to him other than, I do whatever the nurses tell me, right? And he laughed at that and said, "It's funny, I do the same thing." And that became that. I realized it was a little tick then. And about a week after that, he asked me if I could help him get some sleep. He wasn't able to sleep. So, I gave him something a little delicately, and he came back a few nights later and said, "That helped some, but not enough. Can you give me something else?" And, within about a month, he was taking all these medicines, including his psych medicines, that we had spent 20 years at Mass General saying he was resistant to taking. And I'll never forget Barbara looking at me and saying, "See, that's what I'm talking about here." So it was that investment in time and earning trust that let people then decide what they might be willing to accept from us. It was pretty stunning for me to learn that after thinking I knew it all.
I was struck by in the Tracy Kidder book, you said at one point, if people only understood the background of homeless, the path that they've taken, that they just haven't suddenly arrived to be homeless, that so many of them have had brutal backgrounds, brutal childhoods, etc. Can you talk about that?
Yeah, I'm sure not knowing anything about homelessness when I got there, I wasn't sure there were, older men, younger men, kids. It was all an eclectic group of people. But when I looked at the people at the shelter who had been there chronically, and slowly got to know them, I realized that all of my first impressions were completely wrong. And that as I got to know them, which sometimes was only over a week or so, sometimes it took years, then you hear these stories of what they've been through. And then I started to feel I remember that was when I started to think I may not be able to leave this as easily as I thought. Because once they share with you what they've been through, it's kind of mind-blowing. And we have one of the psychiatrists who worked with us full-time for many years was stunned by, if you really probe the very chronically homeless, about their what they happened as children, the number of adverse childhood events was absolutely stunning. The amount of physical and sexual abuse, the neglect, the issues with foster care. And we started to realize that what we're seeing is the end result of something that happened 30 and 40 years ago. And that's why when I think about ending homelessness, I think we've got to fix all of that so we don't have 20 years from now more people coming out. But I was stunned by how, when you really hear the stories, they are leading incredibly courageous lives because they've been given nothing. I've never found anyone who wanted to be homeless, by the way, just for the record. I take that back. One person who I think once really just wanted to be homeless and was homeless. But everybody else is there because of some institutional or social failing, not a personal failing. And I think when you start to realize that, then you feel really, it changes how you think of the population. And I started to understand their anger and why they were angry with healthcare people and angry with me. And
Why were they? Talk about the anger.
it's the same kind of anger I feel when I go to the store and somebody's ignoring me, or I try to get something done and they make me wait forever. It's that kind of, you feel so helpless and the person in front of you isn't helping you, that's how they felt about emergency room. That's how they felt about most doctors. And they loved the nurses because the nurses would soak their feet. I started to realize they didn't get angry with the nurses, but they get angry with me. And I think it was just the anger of that despair, that loss of hope. And you've got to keep on going and you're really angry about what has happened to you.
What's the difference experience between men and women, homeless men and homeless women? How dramatic is the difference between them?
In many ways they're similar, but in other ways it's very dramatic. So the way I first started to realize it, there were stories of men who had ended up at Pine Street because they had severed a relationship, they got fired from work, they started drinking, and then they ended up going from wherever they were straight to Pine Street. And then and Pine Street, by the way, the shelters, most of the shelters we have separate men and women. So Pine Street, the women are in a separate building, so they're very safe. But when we would take care of women there, you never heard a simple story. It was a series of, went from here to there to something else, abuse here, and it's a long journey. So it was quite stunning to me that, for women, the vulnerability that women feel and what they've been through is really quite stunning.
Is there a path out? How often have you seen someone or people throughout the years, 40 years, a path out, a path to something different, a path to what we would say is success?
I cower a little bit at that because we're always reframing what is our objective and what are our goals.
Mm-hmm.
And when we used to think about, we wanted people to get out of homelessness and onto, life, that happened so rarely with at least the people who are chronic, that we had to stop thinking about that. We thought about it in incremental changes, and we would think of, for example, like sobriety. If you can stay sober for a week, that's a victory.
Mm-hmm.
But to stay sober for the rest of your life, maybe down the line some. And I think we did that out of self-defense because you would get discouraged so quickly if you were really hoping. Like, I'll give you an example that when we would have other doctors come, and you guys may remember this, but what happens is you start to take care of someone and realize how the odds are stacked against you, and you get outraged that we as a society would let this happen to someone. Usually someone whose inner part is really sweet but has been damaged by all this. And then you want to change the system, you want to scream. And then the evolution that I know so well is you realize I'm just a doctor, I can't really change society. I wish I could. I can argue and scream and do all that, but I don't have the ability to do that. But I can take care of you. I can take care of the person in front of me as best I can. And when you evolve into that and just let go of some of the other stuff, then you realize there's a whole world of need and important stuff that you could be doing to ease suffering and get to know someone. And then the relationship sort of becomes what's most important.
Is that how you deal with your own anger? Your own anger at the situation, your own anger at knowing that the impossibility of great change. How do you deal with that? How do you deal with your sense of frustration, anger?
Ooh. It is a tough interview, you guys, okay? So, it comes in, I think, to be honest with you, I think we get numb to it and try not to think about it. Because if you did that, it would just paralyze you every day. And so we tend to always look at whatever is good that's happening. In fact, we start all our meetings with what's going well here, And as long as you hold on to those things, then some of the anger can be dissipated a little bit. When I see things like grants pass in a Supreme Court that's probably not going to go there, then I get really angry, but I can't do anything about it. It just makes me furious. But on a day-to-day level, I can let all of that go. I read a book, by the way, by Darcy Fry called The Last Shot. And it's a story of, he's a remarkable writer, and he went down and he met some he hung out with some high school kids in Coney Island who were desperately poor and had really no way out except through basketball. He was following the basketball team. And there were hundreds and hundreds of kids trying to become beyond this Coney Island basketball team. And only a few of them would get on the team. And then as he followed these kids, almost none of them could ever get to the NBA. Although it turns out Stephon Marbury, who was this very famous basketball player, turned out to be one of them. He did make it. And the lesson that I got out of there, every once in a while, somebody does make it. But if you celebrate that person too much, then everybody else feels worse. And so trying to balance that is one of the arts and skills we've had to kind of manage a little bit.
What are some of the myths of homelessness that really rile you if you're sitting? I was just thinking, you're going back to Boston tonight, you're sitting next to someone on the plane, and maybe you're engaged in conversation. They say, "What do you do?" And you tell them what you do. And they pursue a conversation. And what are the sort of myths that people bring to the issue of homelessness that you have to confront? You have to say, that's nonsense.
You're catching me. That's why I pretend I'm asleep now when I get on the planes.
Well, it's 10
especially on the
o'clock.
especially in the red eye. No. I think it's a great question, and I mean, my own family members will do that sometimes. I think a couple things are simple to put to rest. So you guys probably know that Margot Cushell and her colleagues at UCSF just did the big study on the California stuff, and it put to rest this idea that everybody who's homeless comes here because it's good weather. You know, so 90% of the people that they saw in California were Californians. So we have the same problem in Boston. The Boston mayor want to say, "God, we have such great services. Everybody's coming here. We shouldn't have good services so that people don't come here." And that's just simply not true. Almost everybody who we see is from somewhere near Boston, grew up around there. So I think that's an important one to know. These are our neighbors. They're not people that are coming from afar.
Children who we've grown up with.
Exactly. And, you know, and the more I go, the more I know that all of us, including myself, have people in our family that are homeless, you know, so they're not aliens coming from far away or far. And to just grasp that means that they are brothers and sisters, right? We should think of it like that. The other thing is, I think the other misconception is that it's as simple that people are just don't want a job, or they're not, you know, they're malingering or something like that. And I just have never seen anyone who has done that. So it makes me crazy that if you really listen to what's going on, you realize, you know, this person who, you know, grew up unable to read because they had ADD that was not seen and they were labeled as a bad kid, now is homeless. But that's not his fault or her fault. And I think those, getting people to understand that it's not the fault of the people. It's not a personal failure. This is really, we own it. It's a system failure. Some people don't believe that, you know, but it's impossible not to believe that if you hang out with people for a while. So I think that's a big misconception. And then the only other misconception I have is people tend to see whoever they see as homeless, like say drug users on the corner. They think all homeless people are that. And you start to realize that it's a very complicated, eclectic group of people who end up homeless, and that we're going to need as many different solutions to this problem as there are different groups of people. And you can't think of it as a single problem.
Is anyone doing it well? Is any leader anywhere, any mayor, any governor, is there any really creative process going anywhere in the U.S. that you think they're really trying to tackle this, or they're tackling it?
I think there's spectacular stuff going on all over the country. You know, and I could give you lots of examples. The problem always is we learn with a group of 50 or 60 people who are housed in a really wonderful spot with a lot of support do really well. But then we don't ever have the capacity to expand that or scale it to things. So we know what works, but it always seems to be done in small bits, and then nobody picks it up. It becomes a pilot program that never goes on. So, and then I think, you know, different parts of the country they do. I think of, for example, LA, which has, you know, I've spent some time in Skid Row, and I am stunned by the dimension of the problem there. Wouldn't have a clue what to do. Although I think if I were just coming out of residency now, I'd like to go there rather than Boston because it's the biggest challenge. But I've seen in LA some of the most creative ideas about how to solve this problem. The problem is it works for a small number, and they have 40 or 60,000 people they've got to take care of just now. That's just to house the people currently there. Not to mention that there's 400 new people coming every month. So that I think is what the problem is. We've got great ideas that no one has the political juice or will to make national
money?
policy. Or it's all about money, yes. Well, I think it's not all about money. I think it's, where we choose to put our money is one thing, but then it could be solved. Money is, you guys probably know this, but one of the problems with housing right now, so if I step back, so much of the problem now is located in urban areas. So homelessness is going up, went up by 12 to 16% last year, post-COVID, primarily in urban areas. So I think California has a quarter of all the homeless people in the country right now. Most of them are in LA, San Francisco, Sacramento, and places you would know well. And in some parts of the country, the numbers are going down. But we can't, that's hard to sort out, and people don't appreciate that. Houston is an example of a city where the numbers have gone down, and there's lots of
Why have they gone down? What's accounted for that?
I think there's a few things that actually Nicholas Kristof, I don't know if Jeff is here, but he wrote a really interesting article in New York Times about Houston and its issue with, but you know what the key is? In Houston, they were able to get everybody together. The mayor is a strong enough mayor to say, we're going to do all this on one system. So everybody working on homelessness in Houston comes through a central thing. And if the next home available goes to the next person up, it's not 25 people trying to do that. But the real more important thing is Houston has no zoning laws. So if I own a piece of property in Houston right now and decide I want to build a shelter tomorrow, I don't have to go through a community project, just build it. And that turns out to be miraculous when you're trying to build housing. If you try to do that in Boston, it would take you 4 years of community process, and you probably would be told no. So we can't, in big cities with lots of zoning laws, it's really hard to do. But Houston escaped that.
Mentioned in the beginning, Tracy Kidder, in the 5 years he spent with you. When Tracy came to you, he's a great writer. I've read a number of his books. When he came to you, what did you think? What did you say? I'm going to spend all this time with you. How did you welcome him, or how did you think it through? Do I want this guy to hang around?
So you can picture this, you guys. So I had read Mountains. I love Tracy Kidder, the writer. Didn't know him, ever met him, but I had read Mountains Beyond Mountains about Paul, and it was fabulous. If you haven't read that book, you have to read it. It's like really, really special. So Tracy happened to come on the van one night with us, writing a book about a man named Paul English. He was writing a book about him. And I was just kind of thrilled to meet Tracy Kidder. It was like that. But he wasn't there to write a book. He was there he was writing about Paul and wanted to do something on homelessness. And then he showed up a few weeks later and said, I really enjoyed that. I think I might want to hang out and see if I might want to write something. And we said no. And you guys can imagine this because, I knew from Paul, I had talked to Paul Farmer, and Paul had said, just be ready. He's going to be like maple syrup all over you for the next years. And we have, we have all of you would know, we have really intimate relationships with people, and bringing someone into that relationship, especially for years, although we didn't know years at the time, that was not part of it.
Yeah.
And so I had said no, as much as I thought, God, if I would love Tracy Kidder to write about our program. I think that would be great. I thought it'd be good. But I thought the price of asking all of our patients to be involved in that was a lot. And if you've heard me speak, we have on our board of directors, we have a pretty feisty board of directors, but there's several homeless and formerly homeless people on our board. And when they heard Tracy Kidder was interested in writing a book and I had said no, they beat me to smithereens because they said, look, if Tracy Kidder wants to tell the story, we want him to tell the story. And so I sheepishly went back to Tracy and said it was okay, talked to all of our, close patients and stuff, and they were all okay with it. I was surprised. But then I lived in perpetual fear that he was going to write something that was going to really violate something. And then we have HIPAA to deal with. I don't know if he didn't have HIPAA to deal with Mountains Beyond Mountains. So anyone he talked to, and he spent, he had hundreds of people he talked to. He had to get signed permissions that were HIPAA compliant before he could even say anything about them. So I thought that was going to ruin it as well. But it turned out, just to give you a frame shift, I was all wrong. It turned out that he did hang out with us for 3 years every day, and then for another 2 years, several times a week. And then COVID came, and he stopped. But when he finished the book, by the way, just to let you guys know, so I had no, this is his book. He didn't tell us anything about what he was going to write. I didn't see anything until the book came out, right? And if you've ever been through this, you can imagine that over we didn't think it was going to be 3, it was 3 and then 5 years. You can say a lot of stupid stuff during that time. Right? And I was like, oh my God, what's going to be in this book? And then I was petrified about which patient was going to really be really hurt that this was out and said something. And Tracy, to his credit, he turns out to be a wonderful human being, by the way. If you get a chance to meet him, he's just wonderful. But he when the book came out, before it was published out loud, he got a bunch of books and gave one signed with a note to every homeless person that he had talked to. It was really sweet, incredibly sweet. And then frame shift a little bit. The only criticism we've had of this book, which is Tracy's book, of course, is from the people that he had talked to and got to know who are not in the book. And it taught me a lesson that, people want somebody to tell their stories in some, kind way, and they wanted their story. And it was completely the opposite of what I had been afraid of in the beginning.
And what did you think?
I haven't read the book, so I don't
you
know.
haven't?
No, I haven't read it. I tried to read the first little bit. He asked me to read the first part to correct names and stuff, but it's really hard to read someone else's view of what you were doing all that time. So I figured it's safer. I know all the stories. I don't know which ones are in there and how he's weaved them. But so don't tell Tracy I said that. I've never told him that I haven't read the book.
It's a great book. I read it. So we're now going to close this session. Thank you. And we're going to go to questions from the audience here.
Thank you. Appreciate it. I have to acknowledge that next to you, Arash, is Joyce Saki, who I used to adore back in Boston when she was at Beth Israel Hospital. And then she went to Tufts and did all of the community stuff at Tufts. And then I didn't see her until this past week at the American College of Physicians. And here she is at Stanford. I'm so thrilled, Joyce. Didn't you?
We are thrilled to have you.
Oh, maybe I can start with the questions.
Sure.
Well, sorry. Do you mind turning off your? No, yours is fine.
Okay.
Just so the mic can work.
Thank you. So Jim, you've been a source of inspiration for so many students and trainees over the years, and literally had people who wanted to go into medicine because of you. And I guess the question I have for you, having done this work for so many years, do you feel hopeful that academic medical centers are now starting to talk about incorporating the screening of social drivers of health and actually beginning to see that, that's what you for vulnerable populations. We need to actually think about how we activate society to address things like homelessness and things like food insecurities and things like housing insecurity. I was stunned by your reference to the emergency room. And I remember as a resident at Beth Israel Deaconess Medical Center learning literally who was on the streets in Boston, because when you work in the emergency room at night, they show up there. They've been found by the police on the streets, and they come in, they leave. And obviously this is costing us a lot of money to have the emergency room be the place where people are getting their care. So I'm wondering if you think that we're going to finally, as a society, connect the dots and say, actually addressing this issue in the long run will help us to bend the curve when it comes to how much we're spending on healthcare in this country.
You made me think many, many different things here, but I'll tell you what I do feel good about, because this was not what I planned to do. So I don't feel like much of an inspiration that way, because I think I had a lot of great mentors that sort of pushed me to do something that turned out I really loved doing. But what I remember so clearly is that when I did it, I was going out to do something that, there was no career path to. It was, you could do it for a year, and I was going to pay my dues and then go do a traditional thing. And I think because of a lot of support, not only in Boston, but around the country, there's been a percolating of real interest. Think of what Paul Farmer's, there's a percolate of interest in people who are young, going through medical school, idealistic, who can now see that there are career paths in these things, which is huge to me. So I take great, I take some great pride in our profession, in the health professions, that this is the people are trying to help these populations. And we have, I was saying this before, we have, we couldn't find a doctor to work with me for the first 3 or 4 years, mostly because you couldn't afford an apartment in Boston at our salary. But now we have 35 full-time doctors doing this in Boston, probably 40 or 45 nurse practitioners and PAs, and probably 100 nurses. And they're all doing this as their job, and as Barbara, I keep thinking of Barbara, she would be turning in a grave saying, I just want a bunch of people who do this as a job because that's what you want. And it's kind of happened. And I look around, look what's happening here, all over, it's great. And so that, I didn't see that back in 1985. So that gives me great hope. When I step back and look at the problem of homelessness and sort of, disarray in our country and growing income gaps, I get a little nervous that may not change for a while. But I take great hope in young people doing this. Thank you for the question.
Hi.
Julie, I didn't even see you come in. I'm looking around for you and I can't see you, so I must have been okay.
So, first of all, I just have a comment because we were residents together. I was an intern and Jim was a resident then. He was called St. Jim before he started this project. And so I think that John Potts picked you for a real good reason, that he knew what you could do,
Okay.
that he didn't choose the rest of us to do that job. So, but I do have a question that relates to the last time we spoke when you were here.
Mhm.
And it's about the roles of schools in preventing homelessness. And I wonder if you could talk a little bit more about, because this is this is going to be a long process to deal with homelessness and to deal with all the many problems that lead to homelessness. And I'm wondering if you can comment a little bit about how you think schools, working with our schools, can help us to shift the homeless problem.
Yeah, no, thank you for that, Julian. There's a story behind the St. Jim, which I will tell you of it. It was because Roman DeSanctis thought I was a priest who had come to do something, and I was never, and there had been a priest named Jim O'Connell that had been in there, and I wasn't him. So it had nothing to do with my actions, you guys. But
That's not what we were thinking.
But yeah, you know what? When we often tease ourselves to say, okay, we're starting to get a picture of the problem. What would, if you had one thing you could do that would make the biggest difference in homelessness down the line? What would you do? And given that it's never going to get solved unless you get enough housing. So housing is kind of the absolutely necessary part of all this. Not always sufficient, but it's necessary. And I think if I had one thing to do, and I've said that to Julie, is I would fix the school system. I would pay teachers $200,000 a year. I would get universities involved in the school. I would go after the kids. Because what we see on the streets are just people who have been just brutalized during their child, growing up in poor blighted areas, growing up in bad schools, not having any of their emotional things taken care of. And I think if we could just get to them, which is a doable thing, looking at what you were talking about, Arash, then we would make a huge difference in homelessness 20 and 25 years from now. The problem, of course, it would take that time to prove it. And nobody invests in that kind of looking right now, unfortunately. But that's what I would do. I think we should be, we have a daughter who's in 4th grade, and she's at a school that and it was a failing inner city school, and Boston College's School of Education has kind of adopted it, and they get all involved. And it's this vibrant, wonderful place. And I keep thinking, wow, what a great role for the universities to do. And they could do that all over, right? So, but thank you, Julie, for that.
Hi.
Hi.
Oh, My name's Savannah. I'm a program manager with the California Maternal Quality Care Collaborative that's housed in Stanford Medicine.
Yep.
And as a former labor and delivery nurse, I'm curious as your perspective as a physician, to something that I think Joyce had mentioned, the push to screen patients for these health-related social needs and being on the other end of the receiving patients in housing, in need for housing, how we can be better connecting patients who we identify as having housing instability in the inpatient setting and connecting them to those resources. And there seems to be that disconnect of identifying patients, and especially as a nurse, there's not much that I can do aside from making calls at 3 a.m. And having run into those situations in DC and in Miami, where you have very few resources and very few facilities that are, have capacity to bring in more patients that have those needs. So I'm curious about what your organization, your team, what you've seen as helpful, useful structures that we can be implementing, what you see as promising interventions, if you will, to help make those connections.
I appreciate that, and it's you make me squirm a little bit when I think about how to answer it. So just so you know, in our program we had to realize it. So we have adult individual homelessness, and we have a whole part of our program devoted to that. But then there's family homelessness, and we have another part of our program devoted to that. And it turns out they're very, very different issues and different approaches. And just to give you an example, in Massachusetts, do you know we have a right to housing for families? So we have a literal, legitimate. So you don't see a family on the streets of Massachusetts. They get taken up by the state and get housed, or get into a shelter. From there, they'll get housed. That's changing now because we just had this huge influx of migrant families, mostly Haitian families and Venezuelan families, who are coming by the literally hundreds per week, the families. And we've maxed out capacity. But if you leave that aside for a moment, most of our lives, we've been able to, our job is to take care of the kids and the moms and get them hooked into wherever they're going to go get housed, which is usually a matter of months to a year at most. So it's a different kind of a problem. Most of the adults that we see take years and years and years to get housed. So then it's a question of how do you set up long-term care for them. Now that said, what I worry about is a little bit what Joyce was pointing out in the emergency room. We know what to ask people and what to do when they come in. The problem is if there's nothing out there, then you're doing this kind of futile exercise that only makes you and everybody feel worse. So, for example, when we're taking care of people on the street now and doing kids that are in the family shelters, we stop asking about adverse childhood events because every score was too high for us to do anything with. And so that's a bad thing to be in. If we got those scores, we could do something right away with it, it would be perfect. But I worry that we'll do a lot of things, screening and doing all that. But then if we're not going to build the housing and have the right care for them and the therapy that you need and all that, it's really tough. Mm-hmm. And only a few get through, and the rest are now much more aware of what's going on. Mm-hmm. I will, by the way, can I go back and answer Dr. Barry's question, because it just came up so forgive me when I say these, but we have this feisty board of directors, right, with homeless people on it. And they literally are bosses, so they do hire and fire us. So it's like, we got to pay attention to them. And we always struggle. We're called the Boston Healthcare for the Homeless program. We've tried to change it many times, but they won't let us change it because it's been there so long. That's what they know us by. But it says the homeless, which is kind of not a proper way to say things. But that was proper in 1984. And they look at me, they call us routinely. And so we often now say unhoused, and they hate that. No, don't forget, they're speaking just as a group, so that may not be all homeless, but they hate it because they're not looking for a house, they're looking for a home. And they want to keep the emphasis on, I'm homeless, I want a home. And so they much prefer to be called homeless. They hate homeless as a noun, but homeless as an adjective is what they would prefer. And then the two other things they hate, just to share with you, so if I don't say it, forgive me, but they beat me up routinely for saying the proper thing now is to say persons experiencing homelessness. And they think that's what we in academia like to say. And they don't feel like they're experiencing anything, you know? And then they say, it sounds like we're on vacation or something. And so they just say, will you just say, you know, I'm a homeless woman, please, that's what I am. And stop trying to make yourselves feel better by saying it properly. Can you imagine that's what they're saying to us. And the other thing, just to warn you, is we used to always say that we try to integrate mental health and substance abuse care and oral health into a unit. And we sort of changed to say behavioral health. So you can say, you know, mental health and substance use care can be behavioral health. And they went crazy because they hear that as you're impugning our behavior. And we're not trying to, you know, so now we're back to like what we said in 1985 after this whole long journey. And now I don't even want to hear it anymore. You know, it's like, you just can't win. So their take would be, just when you're talking about us and to us, be really respectful and honest, but we don't care about the words as much as we care about the words. Sorry about that, Joyce. I don't know if that goes in. Okay.
So, Jim, I have a question. It's about global homelessness, because I've worked in a lot of very poor countries where you don't see the kind of homelessness that you see in the United States. And then the interesting part with rural versus urban, you don't see the kind of homelessness in rural settings that you see in urban settings. And so the question I have for you, do you think we don't have the extended family anymore that takes in? Is it the wealth gap that you see particularly in urban settings? Is it the lack of a safety net? What are the issues, and why is it that you don't see it? I don't see it in Africa the way I see it here. Well, I can't say all of Africa, a few countries, and they're poor. Madagascar is really poor, but you don't see homeless people in Africa.
You know, that's a probing question that we struggle with a little bit. But if you really step back and look just at our country, the poorest states have the least homelessness. So it's not always related to poverty per se. In the cities that have the widest gap between rich and poor, which then means housing is up, then you see a lot of homelessness. And that often we've taken a lot of beating for. That's often blue cities, you know, that are very progressive and protect, you know, rights of people. So it's complicated. There's several people that have written books about this now that, you know, make sense. And it usually, homelessness tends to be related to the price of an apartment in a city. And the higher it gets, the more homelessness you'll see, and the lower it gets. And in many of the poorer states, you can still rent something pretty cheaply. And there are family structures still in place. Big cities don't have that much anymore. But I think it's largely not understood, to be honest with you. I do want to say one thing about global or local, that I don't know if I told you this, but just to let you know, so I did get to know Paul over many years, from the time he was a student on. This is Paul Farmer. And I would occasionally, when I was really lucky, be on a panel with him, right? And, and he was really irascible in the best of ways. And he would always get up and he would introduce me to this crowd, wherever it was, as this poor doctor who has never gotten more than a mile from medical school. And then he would talk about, you know, Peru, Rwanda, Russia, you know, he'd go all over the place. But then at the end, he would always come back, and this is how he would try to make me feel good after I was humiliated. And then say, but you know, they're finding in a mile from our medical school the same disparities we're seeing in all these other countries. So he would bring it around. That's why I've come to appreciate and was thrilled to speak in a global health class. It is really global. It's a global health issue with with lots of nuances depending on where you are.
The diseases are very similar.
The diseases are exactly the same.
Steve?
Hi. Thank you for a truly inspirational conversation. I have a family member who's a homeless outreach worker, and he says exactly the same thing that I guess your friend Barbara said, which is we don't need any saints. We need people whose job it is to take care of these people. So I really related to that. But I was going to turn to the global question. There's another thing that really bothers me about the comparison of the homeless situation in the United States and elsewhere, and that is here we spend as much on the combination of medical and social care as most Northern European countries, except we spend most of it on medical care, not social services. And this family member that I was just mentioning says it's just crazy how easy it is to get expensive medical care for these homeless patients and homeless people, and how hard it is to get them basic social services. I wonder, like, is there some way that we can bridge that gap? There are these new institutions that basically combine the payments across medical and social services. There's one of them in New York State that I'm familiar with. There's some other way that we can like put this together. It seems to me that it's very consistent with the stories you've been telling.
And no, I really, really appreciate what you're saying, because you're referring, I'm sure, that's study that Elizabeth Bradley and Lauren Taylor did, where they showed, who does well in the world, and then how much you spend on medical and how much on social services, and we're like, a lot of medical, not much on, and we're like 19th in outcomes. And so that's intriguing, and it'd be nice to try to figure that out. And it's the Scandinavian countries that always come out at the top. And when they look carefully into that, they're just very generous with you. If you're not working, you're going to get almost a full salary. There's housing for everybody, and you look at that. But then you step back and you realize it's a very homogeneous population. So there's not a lot of, and the wealth gap is much shorter. So you can imagine if there's a way to get there, but I don't know how to do it. The second problem with that is that, and we're guilty of this because, we realize that we can't do much about getting people housed, but we can try to get them the best chemotherapy and cancer care they possibly could have so that they die like every other American with the best of care and something. But it's exquisitely expensive to do that. And then the question is, how much of that is due to not investing in them earlier, and how much is due to just cancer care? And we don't know. And I said this at the class this morning, and if I could share with you since you're here, I worry a lot about, we just don't study this very well. I can't answer your question because there's no studies past what Elizabeth and Lauren did to try to analyze it even further. And I said this morning too, sorry to repeat myself if you're there, but so my wife Jill was a physician assistant for a long time, worked on the streets for years. I got introduced to her by Barbara McGinnis in the shelter back in the 1990s. And she decided to go get her doctorate in public health because she wanted to do some studying on homelessness, and she'd already done some research on mortality. And she finished her doctorate at great pain because she was much older. And when she was finished at Harvard School of Public Health, she wanted to pursue homelessness or do some homelessness research. And at the School of Public Health at Harvard, and I would argue homelessness is one of the more pressing public health problems, there's not one single person who studies homelessness. And then we looked around at BU, there wasn't anybody there. There was somebody in the School of Social Work, but nobody in the public health school. And then when you step back and say why, it says no federal funding. You can't get a CDC grant. You can't get on homelessness. You could study some small part of like cancer and homelessness, but you can't study the big picture of housing and homelessness and health. And so we have all these really awful studies telling us that, pointing us in a direction, but we have it's not like medicine where we're going to look at what this medicine does for people, not only a year from now, but 3 years and 5 years from now, and see what we need to change. We don't do that. Nobody studies it. So that, I think we could answer that question, but I don't know who's looking at it. Does that make sense? I don't mean to be on that. I try, but one of the things Barbara said is don't preach, and I hope that wasn't a preaching part. Okay. Okay, good, thank you.
Jim, please forgive the personal question, yeah. But you had, I guess, kind of dreams of an academic medical career in one of the biggest systems in the country, and you're still in it at Mass General. But how and when, if at all, did you let go of the dream of being the oncologist or being in that sort of traditional setting? And yeah, I'm just curious how that happened, or if it happened.
It did. I let it go reluctantly, but when I let it go, I really let it go. It was really interesting. Thank you for asking that. And I've had the privilege, by the way, so we are part of the hospital, part of the medical school, and, we're involved in the teaching and the education, all that. So it's like fabulous for us as doctors and nurse practitioners and BA. So we're part of a bigger system than ourselves, which I think is critical, to be very honest with you. But you know what happened? I started, it was 1 year, and I said, I'll do this for a year. And at first I couldn't stand it. And then I started to get hooked. But what hooked me was this TB epidemic that was incredibly difficult to figure out. And I had my last rotation been in the ICU at MGH. I was the senior. And I thought a shelter clinic's gonna be a piece of cake, right? It was way harder and way more medically complicated than I ever dreamed. And then that was the beginning of the AIDS epidemic too, which so we had AIDS and TB all over the place among a bunch of people who didn't even have a bathroom most of the day. And we were overwhelmed, and it was complicated, and much was unknown. So I remember being lost, and that's what I loved, medicine. I wanted to do medicine. I got lost in that, said I'll do it for another year because we just were getting started. But by the end of the second year, to be very honest with you, now I'm getting close to 40, right? So there's a little bit of that going on. But I realized it's too late. I can't do anything, and I like this. This is something I'm really enjoying. So I stayed. So I let it go after that second year. And John Potts was really nice. He delayed my fellowship a second year under some protest, but then I said, you don't have to do the third year. Thank you for asking.
Oh, sorry.
Sorry. Well, first of all, I want to say thank you so much for coming to speak with us. I've followed Dr. Farmer for a while, and it's a pleasure to meet you as well. But I actually wanted to touch on, you mentioned earlier how a lot of this issue, we want to help so much, and then we have this realization of, oh, I'm one person, and a lot of this issue is political. How, if at all, do you think, through the years of your experience, do you think we can appeal to people in these positions that can make these decisions to really, I guess, start to see the humanity, I guess, of the issue and really want to help? Do you have any ideas?
I have some very sort of parochial ideas that may not be, but what I didn't say very carefully, but when we got started, so I got drafted into this, and I started, but it had already been decided what our model of care would be and what was by homeless people working with the mayor. And they were really angry with us, the healthcare system, for not taking care of them. So they had all these proscriptions. So when I started, I didn't realize it. We couldn't use volunteers because that's an act of charity, and we couldn't use students. And I'm coming out of war where students were, a part of everything we did. And to a homeless person, we couldn't use students because their experience had been students coming from a couple classes, primarily at BU Medical School, which was near Pine Street. And some of the students were happy to be there. A lot of them didn't want to be anywhere near a shelter, and they were there to learn physical findings. And so the perception of the homeless people was these kids come down, they feel our organs, and then they go do their clinic somewhere else. So they didn't want to be guinea pigs anymore. That was their perception. And the other thing we couldn't do was do any research. They said no research because there was a big issue about advocacy, which I would urge you to think about, where the advocates who were at that time trying to get the attention of it was a Reagan administration at that time, get their attention, were really focused on, the government had divested from poor and, what am I trying to say, affordable low-income housing, and cut the budget from 90 billion down to less than 20 in today's dollars. And that's why we end up with homelessness. And so that was the advocacy focus, right? And what had happened was there was a psychiatrist at Harvard, who had done a study on homeless families in Boston right at the time we were beginning, just before we were beginning. And the shelters had opened up to them. They did this, what I think, fabulous study about who were what was going on with the kids and who were the moms. And the bottom line was that the moms had been through unspeakable trauma. Many of them were in need of relatively immediate psychiatric care. And the kids were all in need of therapy and psychiatric care. And that came out, and the results of that showed up in the Boston Globe above the fold on a Sunday. And it infuriated the advocates. who all of a sudden saw this as a blame the victim. They said the government is now going to say this isn't a problem of housing, it's a problem of all these broken people, right? And it let everybody off the hook. So they told us, we don't want any research, it just mucks up our advocacy. And believe it or not, to this day, there's a little bit of that around. And what we had to do then was do our work for 5 years. That all went away after 5 years. But for 5 years, we had to prove to them that we would set up an infrastructure, do our job, not complain. And what we found out interesting during that time, that the governor would come to us and say, what are you guys seeing down here? Because we never screamed out loud, we never screamed in the papers. And the mayor would do the same thing. So all of a sudden we're realizing we're at the table now by not challenging, which as a child of the 60s, I felt like a wimp, because this is not what we were supposed to do. You're supposed to scream and march. But we've taken a much more, our attitude toward advocacy is that how do we win them over by letting them see, by being witnesses to what's going on, not being, not screaming and marching. And I think for a large part, that's been a pretty successful thing. That's not to say that we don't need people to march, because I think that should happen. But we are guests in about 45 different sites. And if we get too political, we lose access to the people we want to be at. So we've had that lesson of doing that. So I don't know a real answer to that. I just know if you box into a world like us, advocacy takes on a slightly different thing. And the worst thing right now is for us, is we have 700 people in our program now that are working. Many of them are relatively new. And when there's an issue going on, they want to march on City Hall. So I feel like a wimp saying, nah, you don't want, can we just hold that back? At the same time, I really want them to go march. So, perhaps.
There was a question. Oh,
Yeah.
yeah.
Hi, thanks a lot, and super interesting conversation. I'm curious if you can talk a little bit about kind of the interaction with all the other components. You've talked about housing, about kind of, social cares and so on, and what role as a clinician and as a kind of public health practitioner you think, how do we bridge those gaps, and how have you kind of been able to influence, do the advocacy, not just on those specific issues, but the issues that are more upstream?
That's a great question, and let me. So I don't know, is this off the record? One of the things that has tortured us. Okay, I'm kidding. It can be on the record. Okay. But I believe that when you take care of people, we've got to get them housed. We've got to get them housed, okay? And you think of that as that's square one. You've got to do it. And it's been so hard to get for years. For 25 years, we were on the street and no one was getting housed because they had that complicated way of qualifying for housing. You had to get sober. You had to take medicines. You had to do that. And then the Housing First movement came along, where the government finally said, why don't we house people first, bring them their services later. And so the people that were always at the back of the line now went to the front of the line. And I thought it was, it was heaven. It was manna from heaven. And all these people had been on the streets for years. People we had been literally taking care of for 25 years on the streets, now at the top of the list to get into housing. They went into a Medicaid-supported housing program with supports. And then our board of directors, by the way, just to let you know, made us follow people once they get into housing. We thought once they get into housing, our job was done. But they said, no, if you've been our doctors and nurses for 20 years, you can't just abandon us because we go into housing. So we've had to do our little team does probably 2,000 home visits every year now to people that used to live on the streets. And what we're finding is complicated, okay? And I worry that we've simplified it. I think I would urge you, whenever you hear a simple solution to homelessness, like housing is health, it's not, it's more complicated. Okay, I don't want to argue that it's not, but it's not. But if you look at most studies on housing that have happened, they're all about asthma and lead poisoning and poor housing in poor areas, and it's bad outcomes. So we're assuming now that we get a homeless person into housing, then that's good. And in many ways, mayors are only looking at get them into housing you've seated, right? Nobody's looking at 1 year, 3 years, 5 years down the line. And so, and I could go on and on about this, but what we have found, and we follow people now for 15 years who have been in housing, and the results after 5 and 10 years are terrible. Because whatever drove people to the streets in the first place it doesn't go away just because you go across the threshold. And if anything, they need more services and more help once they're in housing. And we don't pay for that. Okay. And it's only if it's housing in a really nice area with a lot of support do you see really successful things. But there was a National Academy of Sciences, Engineering and Medicine, the old Institute of Medicine, did a study on this looking at does permanent supportive housing, which I firmly believe in, for chronically homeless people, either save money or improve health. And they spent 2 years looking at this. I was the token sort of small R researcher on this. And we looked at the world literature, looked at everything around the country. I thought it was a slam dunk. Are you kidding? And it turns out there wasn't a shred of evidence that permanent supportive housing saves money or improves health. And the reason was what I was saying before, it's not really studied. In the few studies we have, fail because of a regression from the mean. They're looking at 100 people, because they're small, you have to do small. We've done those and I believed it. Okay. Look at 100 people who are homeless and get them into housing. You look at their costs for the year before and the year after, the costs go way down. Turns out if you looked at 100 people who are high users who are not housed and looked at them the next year, their costs go way down. So we have a lot to learn. And what I worry about, just like with the institutional of the mentally ill, we did the right thing in the 60s by closing some of these horrible institutions, getting people out of those institutions, and then we were going to get them into the community where they could have a lot of services and live really much more fulfilling lives. And what do we not do? We didn't provide those services. We emptied the hospitals, we didn't provide the services. And I worry about a parallel with housing. Housing is the right thing to do, just like closing those. But if you don't provide the services, now I'm talking about just the chronically homeless. For most homeless people, you get people a house, they're going to be fine. But of the people we're seeing out in the streets chronically, our results after 5 years is that almost no one is still in housing. After 10 years, almost no one is in housing. After 5 years, only about a third. After a year, 80 to 90% are still in housing. So if you look too short, it looks good. If you look on, looks like a chemotherapy drug,
I think we'll take one last question and then people can help themselves to food. Jenny?
Yeah.
Thank you so much. This has been so inspiring. And so my question is more on an individual level than some of these larger system of questions. So in hearing your story and reading the book, I was particularly impressed by the quality of your interactions with the people that you are serving. And I just think here in California, we see homeless people everywhere. When I drive my daughter to school, we see someone with a sign saying, homeless, hungry, anything helps. She notices it and wants to do something, but sometimes I'm just not sure, what can we do as people to help other people without changing an entire system? And so I'm just curious from your interactions one-on-one with people, what you've seen that has made a difference in someone's life, small or large, that another person can do.
You're hitting a nerve when you say that, and I will answer. But isn't it interesting that, and we have a fourth grader, when they see somebody who's homeless, they can't walk by.
Yeah.
And
Exactly.
isn't it amazing that our kids notice it, but then we get hardened as we go along and just say, nah, we got to move on.
We lose that empathy.
It is an interesting, figure that one out. But we struggle with that. And I go back to the early days with Barbara McGinnis. And Barbara, I would say to her, because I'd walk into the shelter and 50 people would ask me for money and, it'd be like, what do I do? And Barbara pointed out, sort of like the foot soap thing, she said, what people are looking for primarily is recognition. They don't want to be invisible. And so and it's kind of magic in a way. She just said, she doesn't have enough money to give people, but she'll always say hi to them and say, sorry, I don't have any money today, but how you doing? And then move on. So you at least recognize them. There's a great story by, Richard Gere. I say this to medical students and nobody knows who I'm talking about, but Richard Gere was in a movie called Time Out of Mind. And he played an older homeless man in the neighborhood where he lives in New York. And they filmed by putting cameras up in buildings. So there's no cameras down on the street. And he had to testify, or didn't have to, he volunteered to testify when we were trying to get some money from Congress about what it was like and he said, look, I'm Richard Gere, so they did dress me up, but it's my neighborhood, somebody's gonna know. He said, but he spent 8 hours out there and not a single person looked him in the eye. And that's what freaked him out. He said, that's what we miss. And I think there's something to that. All of our board of directors folks say that. So it's not money, it's recognition. Now, if you wanted to give money or something, they would love it, don't get me wrong, but it's really the recognition. So I urge people to, don't feel badly because you can't help everybody, but you can acknowledge the people that you go by. Okay.
Thank
So
you.
I'd like to thank both Paul and Jim for a wonderful conversation and also for the questions and answers. But please help yourself to food, and thank you very much, Jim, for coming today.
Thank you.